Okay. Good afternoon, everyone. Can you guys hear me?
Yep.
Fantastic. All right. So thanks for taking time this afternoon to join in to our monthly CPPI seminar series. And I'm very happy today to present on a project that myself and a few other folks have been working on over the past year. And uh, The title of this project is Development and Feasibility of a Community Pharmacy Driven 24-hour Ambulatory Blood Pressure Monitoring Service. And before I go any further, I'm trying to figure out the turning off the noise for folks jumping in and out. But I think I'm just going to go ahead and get started. So if you'll just ignore the tones that may periodically occur. So let's just go ahead and start. So a little bit of background in terms of why do this project at all? Why is there a need to provide this service to patients in the community? So it's no surprise that high blood pressure is a significant comorbidity and is actually the leading cause of years of life lost in the world, which is a pretty big deal there to say, given that we know there are many comorbidities and many things that certainly lead to increased risk of mortality, increased risk of cardiovascular disease. But high blood pressure, by and large, globally speaking, is a really big deal. In the United States, the diagnosis and management of high blood pressure has largely been based on office readings, and most of our clinical trial data with antihypertensive therapies have been based off clinic type measurements. But if you really look outside of the United States, especially in Europe, there's other types of monitoring, like out of office measurements, that are typically used to try to make a more appropriate or accurate diagnosis of high blood pressure, as well as to help guide management. And so that's really where we're going to focus on today and really provides sort of the background for this particular project. So as I mentioned, out of office blood pressure measurement is used in the United States, and we certainly as clinicians like for patients to check their blood pressure outside of clinic. It can be difficult to get patients to do that. So you can see on the far left here, there's sort of the traditional blood pressure monitoring cuff that you might pick up at your local pharmacy, but it's really up to the patient in terms of, do they take the blood pressure measurements? How frequently do they record their blood pressure? One thing I've encountered a lot is patients may record their blood pressure, but they don't necessarily bring in the readings to the clinic visit. And so then, you're getting this sort of, uh, recall bias of the patients trying to think back to what their most recent measurements were, which is not very reliable. In the middle are a couple of more, say, novel strategies. So the wrist blood pressure cuffs and even watches. The wrist monitors have been around a while, but by and large are not recommended just because they do require a couple extra steps to ensure an appropriate technique, such as holding the wrist monitor at the heart level during the entire reading period. And as you can imagine, everyone has a different wrist size. So small wrist or large wrist, there's not really a way to get a wrist cuff to match the individual patient's wrist. And therefore, you can get some variability in your results. So the American Heart Association doesn't recommend those for routine use, but they are a little bit more convenient. The watches are pretty new. The bottom middle there is a picture from Omron and their product, which was recently released back in 2019. It's not exactly inexpensive, and there's still at least a little bit of debate about the accuracy of the watch, although they did uh, provide sufficient evidence in order to jump onto the marketplace. But again, they run multiple hundreds of dollars per year and haven't really panned out. Along with that, there are a few apps out there that some companies have tried to develop. Needless to say, none of those work very well. And the FDA has discouraged the use of those until that technology further develops. So on the far right, you have here a picture of ambulatory blood pressure monitoring. This is specifically the Oscar 2 ABPM, which is the product that we actually use for this research project. And essentially, the ABPM device the patient wears on a belt clip or sling around their shoulder. And there's a tubing that connects to a blood pressure cuff. And the blood pressure cuff is sized a little bit more accurately to the size of the arm to ensure an accurate reading. And the patient picks up this device and wears it for a full 24-hour period. So that not only includes sort of the day-to-day routine, but even through the nighttime and sleep time. So you really get a good sense of what that patient's blood pressure looks like over a full 24-hour period. So does this matter? So if we think about office-based measurements compared to out-of-office blood pressure measurement, there's pretty clear data out there suggesting or demonstrating that out-of-office blood pressure measurements are actually a better predictor of cardiovascular events and mortality. And by and large, ambulatory blood pressure monitoring specifically has been shown to be superior to a patient simply performing self-measured blood pressure. Now, self-measured blood pressure is a reasonable alternative, but certainly when you look at the data, ABPM is definitely a superior approach to really looking at that patient's risk of cardiovascular disease. 24-hour blood pressure monitoring is the gold standard for diagnosing multiple types of hypertension that I'm going to talk about on the next slide. And this has always been the case. But if you go back, to the very beginning of 24-hour ambulatory blood pressure monitoring back into the 1950s and 1960s, it was primarily used for research only. And it's really only been in the past, I'd say, 20 to 25 years that ambulatory blood pressure monitoring has been used more in clinical practice, albeit much more in Europe than in the United States. So there are various ambulatory blood pressure phenotypes, and the only real way to characterize these phenotypes is with a 24-hour ambulatory blood pressure monitoring period. So if you look at the list of phenotypes on the left, so we have normotensive, sustained hypertension, white coat, masked, and nocturnal hypertension, as well as non-dipping, which sounds a little bit funny. So if you look at the second column, office blood pressure measurement, so a patient that's normotensive, unsurprisingly, is going to have a normal blood pressure, not just in the office-based setting, but also when they're out in their home environment. So if you were to conduct a 24-hour ambulatory blood pressure monitoring period in that patient, you would see that you would have normal blood pressures, not only in clinic, but also at home. Sustained hypertension is essentially hypertension, right? So that's what we think about traditionally when we think about hypertension. And that's a patient where not only do they have consistently elevated office blood pressure, but their 24-hour average is also elevated. White coat and masked hypertension are sort of opposites of each other. So white coat hypertension, which you're probably a little bit more familiar with, is when a patient has an elevated office blood pressure, but they tell you frequently that if they check their blood pressure at home or with a friend's monitor or at the local community pharmacy, that it's normal. And so the only real way to discern sustained and white coat hypertension is to do the 24-hour ambulatory blood pressure monitoring. So in this instance of white coat hypertension, you have an elevated office blood pressure, but the 24-hour average blood pressure with ABPM is less than 130/80 or normal. And so in those patients, we typically at this time do not treat with medication, but more lifestyle type approaches. Masked hypertension, on the other hand, is a patient who has a normal office blood pressure, but then if we were to conduct a 24-hour ABPM, you would find that they would actually be hypertensive in their home environment, which is really interesting. And there's a lot of research going on around masked hypertension. It's a little bit more common, we think, than we previously thought, about 2 to 3% of the population. And one of the big drivers of this, at least one of the main theories, is that a patient's home environment or potentially work environment is so stressful that it actually makes them hypertensive. But when they are in an office setting, clinical setting, because those external stressors are removed, their blood pressure comes down and then you get a normal blood pressure. Nocturnal hypertension, you can do this with patient self-measured blood pressure, but the patient would have to set an alarm clock and wake up a few times during their sleep time to take a blood pressure. So clearly that's inconvenient. 24-hour ABPM is a great alternative because the patient's already wearing the monitor, it's already programmed, and that device is going to take a reading during sleep time automatically, typically every 30 to 60 minutes, depending on how you want to set it up. And so nocturnal hypertension, certainly a risk factor for increased cardiovascular risk as well as mortality. So identifying nocturnal hypertension is really important. But by and large, as you can imagine, we don't do a great job because 24-hour ABPM is not widely implemented in clinical practice, at least in the United States. Non-dipping, so blood pressure follows a diurnal pattern. And so when you wake up first thing in the morning, you have this morning surge where the blood pressure increases as part of the awakening phase, fluctuates throughout the day. And as you get into the nighttime hours, especially during sleep, we should actually see a decrease or a dipping of blood pressure during that sleep time. The lack of that dipping is actually associated with higher cardiovascular risk. And so it's really important to actually understand what happens to the patient's blood pressure during sleep. And again, the most reliable and effective way of doing that is with ABPM. So across the board here, 24-hour blood pressure monitoring is a really effective tool because it really helps you discern these different phenotypes of blood pressure and really identify which ones need to be treated, which ones do not. If we need to adjust the timing of medications to address, say, nocturnal hypertension or non-dipping, it really helps determine how to best diagnose and manage the patient. So as I've alluded to, access to 24-hour ABPM is not great in the United States. There are many barriers to 24-hour ABPM. Certainly the cost of the device is a factor that comes up. So typically for one ABPM, it's around $2,000. So certainly not inexpensive. Just checking the chat here. Okay. Reimbursement, at least historically, has been very limited to white coat hypertension. And I'm going to talk about that later on, where there's actually been some positive changes there. But there are many commercial payers that will actually reimburse for a pretty wide range of indications. A lack of formal training programs. So you do have to have trained staff to set up the device, to know how to educate the patient on what to do when they bring it back. You have to download the results with a special software. And then you have to know how to interpret the data that you're getting. And as you can imagine, having some training would be a big plus. But as it is right now, there's really not a formal program to learn how to do that. And willingness of the patient to complete the test. So you have to wear this device. It's not exactly super fun to wear. I've worn it myself a couple times, especially during sleep. And so as you can imagine, some patients get a little bit hesitant, particularly if their work environment is one where maybe they don't want their coworkers to know that they have high blood pressure or that they're having this test done. So certainly those are some things that have to be factored in to any time that you're offering ABPM. But one of the big barriers is accessibility, and that's really one of the key things that we wanted to focus in on with this project. So in other countries, ABPM, especially in Europe, much more widely utilized and is actually preferred over patient self-measured blood pressure. Ireland is sort of the example that I ran across in the literature that really made me think about doing this to begin with. There was a study where they looked at the blood pressure characteristics of quite a number of patients that had 24-hour ABPM performed by either community pharmacies and or primary care practices. They looked at patients that had the ABPM testing in both settings to compare to see how consistent the results were. And by and large, the community pharmacies were comparable to the data that they were getting from primary care, suggesting that community pharmacies might be a great way to increase access. And actually in Ireland, this is very much the way that they do it. And a couple of other European countries do it the same way. So that got me thinking, why not in the United States? Community pharmacies are a great way to provide certain services to patients. If you think about our success with vaccinations, point of care testing, prevention and wellness, it seems like a natural fit. All right, so the objectives. So the primary objective was to really see if we could do this, right? So we wanted to develop and evaluate the feasibility of a community pharmacy-driven ABPM service in the United States. Even if you go back to the Ireland study I just mentioned, they really didn't focus on, how do you implement this, right? So what does it look like in the pharmacy? What does the workflow look like? It was very much focused on comparing the data between community pharmacy and primary care. So what we wanted to do is really focus in on the actual process and the feasibility of doing this in the US. As far as secondary objectives, we obviously wanted to characterize the types of referrals we were getting, as well as the participants. What did the ABPM findings show, especially in regard to blood pressure phenotypes, which again, many of which are associated with higher cardiovascular risk and can really help drive the diagnosis and management of hypertension. So anytime you're doing practice-based research, you need practice partners, right? So we were very fortunate to have some previously established relationships with two local independent community pharmacies in the Richmond area. Buford Road Pharmacy, which is just a few miles from my house here on the south side. And then Bremo Pharmacy, which actually has two locations. The one we focused on was Bremo Pharmacy at Henrico Doctors Hospital, thinking that co-location with the health system as well as other medical practices that were on site might really help in terms of getting referrals. Both of these pharmacies already provide many different types of progressive community pharmacy services. We also like the fact that they had some established relationships with medical practices, so it was very easy to set up a meeting with some of the medical practices, go in, have a face-to-face conversation to actually advertise and promote the service. So I mentioned training earlier. Since there's no formal training program, we had to create one. And so given my own experience clinically, as well as from a research standpoint with 24-hour ABPM, I created a 2-hour training program that really focused on a very basic review of hypertension, how blood pressure fluctuates throughout a 24-hour period, going through some of the guidelines and statements that have been put out about ABPM, as well as the interpretation aspects. But as you can imagine, the training was really much more than these 2 hours. Once we got sites set up, there was on-site training as well as ongoing support throughout the entire study period. Each pharmacy designated a lead pharmacist and a pharmacy technician to really drive implementing the program. So that way we didn't have, 5 or 6 pharmacists and, we were going to have issues coordinating who is scheduled on what day. And so both pharmacies identified leads to really focus in on providing the service. And they had designated days also, and it was appointment based. So that way they wouldn't have patients just randomly showing up in creating a situation where, they're really busy just dispensing prescriptions and trying to stay on top of that. And so that appointment based approach, I think, is really, really critical. I mentioned marketing, which I think is a big part of this. So both pharmacies did receive a marketing budget, which really focused on them setting up face-to-face lunch meetings most of the time with medical practices. We identified, several for each pharmacy to go and meet with. Either myself or one of the other co-investigators went with them to provide a little bit more in-depth information about ABPM monitoring. We also created information flyers that were handed out. We had a show and tell, which is always fun, right? It works for kindergarten all the way up to older adults if you can have something to actually show and talk about. So we did take one of the devices and kind of explain and, make sure they really understood what ambulatory blood pressure monitoring was and how it differed from traditional patient self-measured blood pressure. So as far as the methods, pretty straightforward. This is a single-arm clinical trial. We did have to register it. We really wanted to focus on patient satisfaction. Again, this is a, no one's ever done this before type of thing. So really wanting to focus on, how acceptable this was going to be from the patient standpoint. And Our inclusion criteria, we only focused on adults. They had to be suspected by their provider of having either white coat, MAST, sustained hypertension, or suspected of having hypotension. So certainly if you suspect a patient's having episodes where their blood pressure is dropping too low, that would be good information to know. Or if it was a patient where the provider needed additional information to be able to confirm that initial hypertension diagnosis. We excluded patients with persistent atrial fibrillation. It's not ideal in a patient with atrial fibrillation to do a BPM because you will get some variation in blood pressure and heart rate from the atrial fibrillation, so it makes it a little bit more challenging. Pregnant patients we excluded, as well as those that were on hemodialysis, as well as dementia. The analysis, very straightforward here. Descriptive statistics, really looking at our patient satisfaction data, looking at the baseline demographics of the referrals. So who was referred, what was their past medical history like? What types of providers referred patients? Was it all physicians? Were there advanced practice providers referring? And then obviously doing a deep dive on the ABPM findings and our survey data. So to give you just a brief outline of the workflow here. So a provider would essentially refer the patient to the service. We did have a referral form that the provider could fill out. And that form, we were able to get patient's name, their phone number. The provider was able to use a checkbox and kind of check off, what they suspected was going on. That form was faxed to the pharmacy. Both pharmacy logos and information were put on the referral form so the patient could look and kind of identify, which pharmacy would be most convenient for them. Once the fax was received at the pharmacy staff would call up the patient and actually schedule an ABPM appointment. They'd also go through and ask a couple questions just to make sure, that the patient was comfortable coming in, made them aware that, this would be a study and they would be participating in a study. And so once the patient actually came into the pharmacy staff then consented the patient, written consent, so the patient could participate. And then the pharmacy staff programmed the ABPM device. So there's some pretty standard software that you put on a laptop. USB plugs into the ABPM device, plug it into the computer, kind of programs it, and put in some patient information, and that's pretty much it. The setup on average took about 20 minutes. And that's keeping in mind, that they had to consent the patient and set up the device. So, a good chunk of that 20 minutes was, I'm sure, the consent process, whereas the setup, is pretty quick, especially if you do it a couple of times. The patients received an education sheet of some do's and don'ts. You obviously don't want to get in the shower wearing your ABPM monitor. You don't want to go swimming. We don't want you to take like a long nap in the middle of the day, especially if that's something you don't normally do, although that sounds pretty tempting right now. And then a follow-up appointment was scheduled, ideally within 72 hours. Obviously, if the patient could bring it back the next day, that was optimal, but certainly we had some flexibility that might take a day or two for the patient to come back. So when the patient returned, the pharmacist, again, just with a USB cable, plugged into the device, into the computer, and then you download the results. And during that is when the patient completed the patient satisfaction survey. And then the pharmacist was able to review the data, give the patient sort of a brief overview of what was going on. And then those results were faxed back to the referring provider, along with some recommendations if the pharmacist felt comfortable. And this wasn't a key focus of this project, some of these clinical aspects. And we didn't know which practices were going to refer patients. So it was very difficult to try to set up a way to gather data on, what happens, like how did the provider use this data, to change their practice. And that was one part that we didn't, collect as part of the study. But once the provider received those recommendations, that pretty much ended the patient's participation in the project. So we had a 6-month enrollment period, and during this time, we had a total of 58 patients referred. First couple of months were a little bit slow, and then really right toward the end of 2019, things really picked up, which was great. But with one of the sites, it certainly was a little bit overwhelming. So we did pick up a couple other loaner ABPM devices from the manufacturer of this device, just to make sure we didn't have to wait list patients. Since this was part of a study, we didn't really want them having to wait a couple of weeks to get the monitor. We wanted to be able to provide it pretty quickly and get the data to the provider pretty quickly. So with the 58 that were referred, we only had 6 that simply just didn't show, which was, I thought, quite good. 3 of those just simply didn't answer the phone. And 3 did answer the phone, scheduled an appointment, but just never showed. So we did enroll 52 patients during the 6-month enrollment period. So what did the patients look like? So what's the patient demographics? So of the 52 patients, we had a mean age of about 57 years. 3/4 of the patients were white, but we did have pretty good minority representation. You can see with almost 20% Black, 6% other, 50-50 split between men and women. And unsurprisingly, an overwhelming majority did have an existing diagnosis of hypertension. Other common comorbidities, again, no major surprise there. Hyperlipidemia, current smoker, almost 20%. A little over 15% had prior atherosclerotic cardiovascular disease, and about 6% of patients had chronic kidney disease at baseline. Almost 2/3 of patients did monitor their blood pressure at home, and you can see that about 2/3 of those monitored their blood pressure at least daily. A little bit surprising, but I guess not. I mean, thinking about the types of patients that are going to be referred for this type of service, typically it's helpful to have some indicator of what the home blood pressures may look like. That would then lead the provider to suspect something like a white coat or mass hypertension. And so we did have one patient that did have previous experience with having ambulatory blood pressure monitoring performed, but it was several years ago and the patient didn't really remember much about that experience, which may have been a good thing. So about the referrals. So we had referrals from nurse practitioners, physicians, and then we had some self-referrals as well, which was completely reasonable. Both pharmacies advertised the service at their pharmacies and, could certainly have patients come up and ask to do it. So interestingly, 48% of the referrals were from nurse practitioners and 40% from physicians. Reason for the referral. So what was the box that the provider checked? By and large, the biggest concern was white coat hypertension and almost half of the referrals. Sustained hypertension, a good chunk, and you can see the rest there. The referral visit blood pressure data. So the mean blood pressure at the last office visit before the patient was referred, you can see an average of about 142/83, which is certainly hypertensive. And somewhat unsurprisingly, maybe, although this number is a little low, but you can see that based on that last office visit, only 17% of patients were actually at their blood pressure goal. And we did ask for individualized blood pressure goals in case some providers wanted to focus on 140/90 or 130/80, since there's some debate there about which goal is optimal. But either way, you look at it, the blood pressure control rate was pretty low. 2/3 of participants were taking some type of antihypertensive regimen at baseline. ACEs, ARBs, diuretics were quite common. Beta blockers, about 23% of patients. We did have a number of cardiology practices referring patients, so that may be why the beta blocker use was a little bit on the high side, given that we try not to use that too much as a first or second line choice, or even third line choice for essential run-of-the-mill hypertension. So getting to some results, So patient satisfaction. So out of the 52 patients we enrolled, 50 of them completed the patient satisfaction survey, which is pretty good. You can see at the very top, the overall satisfaction with the experience using the service. So 88% strongly agreed or agreed with that statement. Just from reviewing, there was a comment box on the satisfaction survey, and a couple of folks, the comments I remember seeing, it was really more about their experience with the monitor than the service per se. So it may have been that they didn't like wearing the monitor, or the monitor maybe woke them up. But again, I think 88% is pretty good. You can see a lot of green and light green here. So a lot of patients strongly agreed or agreed with a lot of the statements. I did want to point out a couple more things. So 100% responded that they felt they were treated professionally by the pharmacy staff, which I think is terrific, unsurprising, right? Another 100% of participants stated or agreed that the pharmacist clearly explained the benefit of undergoing this testing, which was good to hear, and at least gives me some comfort that the training and stuff was somewhat effective, and that the pharmacist could clearly explain why they were doing the testing and what it was all about. If you look at the one just below that, they were also asked if their doctor clearly explained the benefit of undergoing the testing. You can see there was at least 6% said neutral. Some folks disagreed with that statement. Not going to get into running statistics given the sample size here, and doing this with the Likert scale is a little bit complicated, but an interesting finding nonetheless. Large percentage thought that it was easy to go to a community pharmacy to have the testing done, which again, I think speaks very favorably to the service as well. So by and large, we're very satisfied with these results. The survey was based off of a pre-existing survey that was designed specifically for ABPM that was published a few years back. And we adapted that minimally to meet our needs and seemed to work pretty well. And I'm going to take a drink of water. So folks were satisfied with the service, but what did the ABPM data actually tell us? So if we look at the data, we did have 46 participants that had a quality test so that we could actually make some determination about their blood pressure phenotype. So basically we have to capture, excuse me, at least 70% of the readings in order for it to be a qualified test. So that's where the 46 comes from out of the 52. You can see that nocturnal hypertension was extremely common, almost 100%. This can be a little bit difficult to interpret. It could certainly be that if you're wearing this monitor, you're not sleeping as well, maybe, or maybe the patient got up a couple of times and they forgot to tell us about that. We did, get information back from the patients after wearing the device about any abnormal things that might have happened. Like, again, if they were getting up multiple times throughout the night, or if they took a long nap in the middle of the day and they stayed up half the night. But even if you adjust for some of that, it's still a pretty high rate of nocturnal hypertension. Non-dipping status, which again is going to go hand in hand generally with nocturnal hypertension, about half of participants. Sustained hypertension, so 40%, 41% continued to have elevated blood pressure, and really, these were folks that needed additional antihypertensive therapy and lifestyle change to manage their blood pressure. 24% normotensive. White coat hypertension, we definitely identified that in a number of patients. And again, those are folks typically that we're not going to treat with medication. So it's important to identify that so that we don't end up over-treating folks. And we did have 2%, which is really one person, that we did confirm as having masked hypertension. So all of the phenotypes are present here, even in the sample of just 46 people. So why is this important? Like I said, it's certainly informative and can prevent not just undertreating patients who continue to have high blood pressure, but also prevent the overtreatment, which can lead to adverse events and side effects. Also helps identify those who may be at higher risk, right? So the nocturnal hypertension, non-dipping type patients, even the white coat patients and masked hypertension patients are also at higher cardiovascular risk. So identifying that, I think, is really important to kind of help risk stratify patients from a cardiovascular standpoint. So the million-dollar question, reimbursements. We did have successful reimbursement for 3 participants that had commercial insurance. Unsurprisingly, this was an area that we hit had some barriers popped up, but pharmacies are not eligible to reimburse under Medicare. So even though CMS does have some reimbursement options, the pharmacies themselves are not coded the right way to bill. And I'll come back to that in a little bit. Right before the study, the American Medical Association and the American Heart Association sent a letter to CMS actually advocating that coverage for ABPM be expanded, which led to some additional work that Dr. Salgado and I did in doing a qualitative analysis of this open public comment period on coverage that CMS had. So basically, they wanted to get feedback from clinicians, organizations, really anyone about ABPM and how important they felt it was. And so we did a qualitative analysis of these comments. And during the open comment period, CMS received 103 comments, mostly from physicians, but there were some pharmacists that also responded. And some of the key issues that were reported came up, the limitations of the current policy, which is very limited to white coat hypertension only, barriers to current use of ABPM, access came up quite a bit there, the impact of inadequate coverage on patients and providers. So being able to provide the service that could really help inform the clinical decision-making, not having that available, the argument was that that could lead to lesser care and really helping patients, figure out what's going on with their blood pressure so it could be managed appropriately. As well as from a business perspective of the clinics trying to provide this service. Some of them provide it, for free and just take a hit. And so certainly the coverage aspect is something that goes beyond just pharmacy and is a big issue that's receiving a lot of attention. So as a result of all of this, in July of 2019, which is right as we were getting started with our study, CMS removed some of the restrictions for getting reimbursed for white coat hypertension. They added the reimbursement for masked hypertension. And they revised some of the language, whereas previously you had to be a physician to interpret the data. They did take that out, they added that the interpretation could be done by a physician or a non-physician practitioner, which is true, but then from a reimbursement standpoint, because pharmacists are not providers under the Social Security Act, from a reimbursement standpoint, that doesn't include a pharmacist. So it's a little bit tricky there. But needless to say, it's expected that over the next year, as this trickles down to the commercial payers, that there will be at least a little bit more coverage and expansion of coverage from a commercial standpoint. So I still think that there's opportunity, and we did have some success with commercial payers. So what does the future look like for this? So in the interim, after we ended the study enrollment period, both pharmacies wanted to continue to offer the service and charge a $50 fee. And within the first month of doing it this way, they did complete 10 tests and patients were happy to pay the $50. So obviously that's not going to work for everyone, but certainly there can be a cash flow type business aspect to this. One of the big things we're exploring right now, or before COVID-19, I should say, is a shared reimbursement model with a cardiology practice. So Bremo Pharmacy at Henrico Doctors has a really great relationship with the cardiology practice there. And the idea would be that they would enter into this jointly and the practice would help manage the reimbursement process and then split the revenue with the pharmacy. And, we're still working on that. So we had a meeting scheduled and everything, and then COVID-19 hit. And so, that's been on the back burner, but I'm sure we will be picking that conversation up soon. And I think that could lead to additional opportunities for the pharmacy in terms of maybe trying to provide recommendations or even get into management, maybe a collaborative practice, and potentially even expand the role of the community pharmacy at that practice beyond just ABPM. So we're really excited about that. And as I mentioned, I think coverage will improve as this new decision memo by CMS is implemented and adopted by commercial payers. So kind of big picture, what does the value proposition look like? So for 24-hour blood pressure monitoring, I think there's a wide range of customers, right? So our patients, certainly, medical practices and health systems, which I think are two key customers there, primary customers, as well as payers. The anecdotal feedback we got from the medical practices was highly positive. There were a couple practices that really adopted this. We are planning to do some interviews, both with the pharmacy staff that provided the service, as well as the providers that referred patients, to really get down in the weeds and kind of understand their perspectives to kind of inform further implementation. The benefits of ABPM are pretty clear, and there's a number of studies demonstrating that ABPM is cost effective. And so what we have to figure out now is it cost effective if, say, the community pharmacy provides the service? Is it cost effective if it's provided by, say, a primary care clinic? And so we're trying to work through that now with some modeling data, with a modeling approach, using some data that is available. It certainly provides more accurate diagnosing, which should, right, improve the management of high blood pressure, reduce over and under treatment, both of which can lead to increased cost. And why community pharmacies? I mean, I think we know this, but I don't know, again, that the broader community does. Community pharmacies are easily accessible, visited frequently. People go to their community pharmacy much more than their doctor. Reduces the burden on medical practices and health systems to set up their own program. I've been in conversations with folks at VCU in a couple of different areas that have had interest in an ABPM, but the idea of setting all this up themselves is cumbersome. So the idea of having, a healthcare professional to defer to provide the service is very much appealing. We did at least have some initial conversations with VCU Health about a partnership. And again, that was right before COVID-19. So we'll have to pick that up at some point in the near future. The potential to combine with other pharmacists. So as I mentioned, whether it's MTM, adherence, there's lots of things here that the community pharmacy can provide that can improve blood pressure outcomes. And I think that ABPM is a tool in the toolbox of services around hypertension management, and certainly I think something that warrants further exploration. So to wrap up, to our knowledge, so this is the first study to report on the development and feasibility of a 24-hour ABPM service in community pharmacies. Most patients in our study were found to have sustained hypertension, be normotensive, or have white coat hypertension, and over half of our patients exhibited a non-dipper pattern at night, which again is associated with higher cardiovascular risk and is more predictive of risk than daytime blood pressure. Patient satisfaction with the pharmacy staff and the service itself was quite high. Future research certainly need to focus on the clinical and economic impact of ABPM. Ideally, one of the things that we've certainly had conversations about is adding in a couple more pharmacies and trying to grow the network a little bit, as well as trying to shore up some of our relationships with some of the medical practices. And I think that will be a key part of this moving forward. So no good project is done alone. I'd really like to thank my co-investigators, Dr. Patterson, Gatewood, Salgado, and Holdford, as well as Julia Skrigsby, who's a pharmacy student who really helped a lot with the data collection in many aspects. Obviously, our practice partners and the pharmacists at both sites. The study was sponsored by the Community Pharmacy Foundation, so I want to thank them for their support. Suntech Medical, that makes the device, provided unconditional support with a couple loaner devices, and providing some advice on different aspects of ABPM, but certainly played no role within the study itself, but I would like to acknowledge their role. With that, I will happily take any questions.
Dave, this is Yusuf. Thank you so much for the really nice presentation there. I really appreciate it. It was very informative from a feasibility standpoint. I actually have two questions. One is, given that you had a good representation of African American in your study, have you looked at the hypertension phenotype based on different racial group? And then the second question is, this is more of exploratory, given a personal interest in this. What's the role you think that continuous blood monitoring would have on resistant hypertension?
So both good questions, and thanks for your comment. So the first question was looking at the racial ethnic differences, and I'm actually working on the manuscript right now. Is pretty much done, and that's one of the things that I have on my list to go back and look at. So thank you for bringing that up. We also wanted to look at, the physicians when they refer, or providers when they referred participants. They had an idea of what was going on. It'd be interesting to look and see, like, afterwards, how many of them were right, based on their kind of clinical suspicion versus what the actual ABPM data showed. As far as your second question, which, if I understand right, is it looking at the role of ABPM in resistant hypertension? Is that correct?
That's correct. Yep.
So there's, I'd say, pretty good data out there showing that ABPM can be helpful in guiding therapeutic decisions in resistant hypertension. But I'd say that, sort of the definitive, randomized or pragmatic type clinical trial has not been done really. There's a couple of papers that have looked at the impact of pharmacist interventions in patients with uncontrolled hypertension on ABPM, on the blood pressure data that you get, but not really using the ABPM to sort of guide and inform decision making. That's definitely an area where we don't know as much, and certainly something that I have interest in looking at. Great questions.
Thank you.
Another question, would it be worthwhile to collect data going for longer than 24 hours, like 7 days? We're wondering if the pressure of adjusting to the situation also contributes to the blood pressure. Great question. So there are some studies that have gone out to 48 and even 72 hours. A couple of limitations with that is, again, just from my experience with this, as well as some data with patient acceptance, is getting the patient to wear it for an extended period of time. Particularly, I can talk a patient through, can you do this for like one night? You wear this for one night, you don't have to wear it, again, probably. I can get patients to buy into it, but if I had to tell them they had to wear it for 2 or 3 nights, or 7 nights, I think that would certainly get some pushback. The device is powered by AA batteries, and so certainly you would have to change out batteries because you wouldn't want the device to die on you. And at least so far, there's no evidence to show that 48 or 72 consecutive hours is more beneficial than 24 hours. And all of the data that has shown an association with ABPM and cardiovascular risk and cardiovascular mortality, that data is by and large with 24 hours worth of data. So maybe, and certainly the interval at which we repeat ABPM, if you do it once, should you do it again in a month? Should you do it again in 6 months or a year? Don't quite know. Typically once a year is what's recommended right now, but even that's not really based on great evidence, it's more opinion. Good question.
Hi, Dr. Dixon. This is Vasco. Thank you so much for this presentation.
Thanks.
I think it was really interesting. I've seen the decision tree that Tyler has been working on for his pharmacoeconomics class. So considering that this device is somewhat expensive, and provided that there's economic rationale for providing the service in the pharmacy, what does the monetization plan look like? Like, who's paying for the service? Is it who's the main customer really? Is it the a physician? Is it a health system? Is it the patient? And in considering that these are the main customers, what does the monetization look like?
Good question. So I would say that, trying to do a one-off, with a provider, probably not a great plan. I think trying to work with the health systems, potentially even the payers. So self blood pressure monitoring out of the office is now reimbursable, sort of your traditional blood pressure monitoring. There are some new quality measures coming out around patients, or not just patients, but any type of blood pressure monitoring that happens outside of the office. So I think the idea of the partnership between the payers and the health system with the pharmacies that are offering the service to provide that access, to me, makes the most sense. The reimbursement with the full, the full gamut, doing the testing, providing the interpretation and everything, the reimbursement for a single session can be as high as about $175. And as far as the initial setup, again, on average for us, about 20 minutes, probably be done in 10. The bringing back the monitor, downloading the results and all of that, another 10 to 15 minutes. We did try to streamline the use of a pharmacy technician with, just simply like plugging in the device and pushing the button to program the device, putting it physically on the patient, so the pharmacist was really focused on, the high level stuff, like, at the very end, counseling to make sure the patient knew what to do with the monitor in case something happened. And then when they bring it back, so that they'd understand the results and providing the actual interpretation. And so by trying to streamline that, you can certainly reduce some costs there. But I do think that it's a tool that's better aligned with sort of a value-based approach than, getting reimbursed for each time you offer the service. Does that make sense?
Absolutely, absolutely, and that's precisely why I was asking this, because in a providing the service in an integrated pack of services that the pharmacy has negotiated with a payer is probably more sustainable, or at least provides more opportunity for a continued relationship, as opposed to just like a one-off type of assessment for blood pressure specific. So cool, thank you.
There's one study going on in older adults where they're looking at the ABPM data and relationship with risk of falls in older adults. And so I think that there are some other potential mechanisms where you could certainly demonstrate some cost effectiveness. If you're identifying, and especially in older adults, that they're having more hypotensive episodes than you think they are, and you can adjust therapy or discontinue therapy, what have you. And, if you can prevent a couple of falls, that's really going to change the equation from a cost benefit standpoint.
Absolutely. Well, thank you. Thank you so much.
Thank you. Any other questions? I think we have 2 or 3 minutes.